All right, so the goal for this session is for everyone to kind of walk away with a better understanding of patient-family-centered care and what it is not. That is just as important. And then hopefully you'll be able to identify some patient-family-centered care practices that you can implement to improve the patient experience. So whether it's a practicum placement here at ACH, they really can apply to any setting, whether it's in the community or at a school or another hospital. And some of this might be some reminders, but hopefully there will be a nugget or two where that is new and that it'll be an aha for your practice. So what is patient and family-centered care? I'd love for a couple of you to come off your mute, your mic, and just give me an example of what patient and family-centered care might look like, what it might feel like. And we're not going to move on until at least a couple of you come off. So let's make this interesting.
Don't be shy.
This is your chance. There's no right or wrong answer per se. This is just an opportunity to share with your peers.
Okay, I'll say a little something. I think that patient and family-centered care, they kind of go hand in hand, because as we've been learning throughout nursing is that a patient's environment and the people that they socialize and live with actually have a huge impact on health. So as a nurse, kind of understanding the individual patient health, but also looking broader into their environments and things like that for a better understanding of their health.
Yes, thank you, Kendra. Absolutely. You touched on a lot of great points. All right. Who's going to add something else to this conversation?
Hi. I think, especially coming out of like maternal newborn into this, I think looking at patient and family-centered care in regards to how much teaching is going on, just because everyone's learning so much, and all the developmental milestones, especially with children, kind of empowering kind of the kid to kind of know what's going on a little bit, but also empowering the parents to kind of teach them what to be looking out for and what are certain, like what's normal at 12 months, what's normal at 18 months, kind of a thing. So I would say, yeah, a big focus on patient teaching and getting everybody involved and kind of empowering them and stuff like that.
Great, thanks, Chloe. Yeah, so you touched on a couple of points as well, participation, information sharing. So thank you for Kendra and Chloe for volunteering. It just shows that my internet was unstable. I'm at the Children's Hospital right now, so let's hope technology is my friend today. So a lot of organizations have come up with a definition of patient-family-centered care, and at the core are these four kind of formal principles: respect and dignity, participation, information sharing, and collaboration. And here at ACH, we've embraced these four principles into a mission statement about working together and recognizing that everyone has strengths that that are brought to the table. So research has found, and sometimes it's hard to do research specifically on patient-family-centered care because there's so many kind of confounding variables, but we do know that when we practice patient-family-centered care, we've found that improves follow-through with treatment. So if somebody understands, if the information is being communicated to them in a clear way that is appropriate for them, that it's much easier for them to follow through with treatment. Of course, it also increases family confidence. In addition to family satisfaction, we found that it also increases staff satisfaction, creates a positive experience for staff as well if they're able to create those connections and relationships in a meaningful way with patients and their families. And it also contributes to a safer practice. I know one of the challenges for nurses on a unit is when they come into the room and they need to do vitals and the child's just fallen asleep, and the parent might be like, hey, it's taken me so long to get my child to fall asleep. Can you come back at another time? And maybe there's a window that's appropriate, but there's a reason why you've got some standards in place in terms of how often things should be checked. So patient-family-centered care When you communicate the reasons why to a family, it can help create that kind of safer practice partnership. And it's been found to decrease the length of hospitalization, readmission, and emergency visits. So bottom dollar benefits. So as I mentioned, we're also going to talk about what it isn't. And despite the fact that we've been practicing family-centered care here at ACH for decades, there's still some myths that exist within the hospital, and there's still pockets of some misassumptions, or people think it's if they do something, then it's not family-centered care when really you are practicing family-centered care. So I'll give you some more tangible examples. So it's not doing whatever patients and families want. So as I mentioned, if you walk into a patient room and you need to check the patient's IV and the family member says, please don't touch my child's arm, they've just fallen asleep, can you come back in 3 hours? And you know that that's not committing to a safe practice. It's not just saying, yeah, sure, I'll come back in 3 hours. It's again explaining why you need to do it and how you're trying to prevent any infections from happening or delaying their ability to leave the hospital. Nor is it expecting parents to be there 24/7. A lot of families, I think, Kendra, you mentioned in your example that you got to look at kind of a more holistic view, the environmental factors. What if that family or that, let's say, mom has 2 other children at home or has to keep her job to put food and shelter and clothing? It might be very difficult for families to be there 24/7. So it's understanding and accepting that it doesn't mean the parents don't care, that they don't love their child. And sometimes it's a matter of understanding what maybe some of the barriers are for the family to come to the hospital. There's one particular situation where a mom hadn't been in the hospital for 2 weeks. And of course, people were jumping to conclusions. And finally, somebody asked this mom, is there any barriers? And of course, they used words that were appropriate for that particular conversation. And they learned that this lady was relying on transit. She lived at the far end of the city, and she was struggling to keep her job and keep everything going. So they were able to give her taxi vouchers for her to come to the hospital more often. And nor is patient family-centered care tolerating disrespectful or abusive behavior. Absolutely not. But I'm sure you'll very much appreciate when you, if you haven't already had practicum experience at an either adult hospital or elsewhere, sometimes, especially here at ACH with children, many families come to the hospital with very little sleep. They're completely worried and concerned, and when they're here, it's almost impossible to get a good night's sleep. So sometimes families are not always on their best behavior in the sense that things don't come out as nicely, and it might come across as, not exactly polite. But there's a difference between someone who doesn't have much sleep underneath their belt versus someone who's abusive. And again, don't expect you to tolerate abusive behavior, but know that if someone says something or is reacting in a negative way, to figure out, well, what is the cause of it? Are they tired? Are they worried or concerned? Or is there something else going on that you need to put some protective processes in place? Already talked about compromising safety standards. Again, safety comes first, but it's all in how you go about it. A lot of families don't like to be told, well, it's policy that we do that this way. I mean, I think most of you are young and may not have children yet, but if your parent was to say, or your boss, like, no, this is just the way it's done, versus, hey, I need you to do this, and here's the reason why, you're able to digest it better, and you'll proceed with whatever's being asked of you in a much more positive way. And patient family care is not a static process that has a specific start and end point. When a child's in the hospital, there could be acute periods, there could be periods of stability, and there could be waves of that within one hospital stay. And even within that, it's not always a simple, easy practice. And it can be very challenging. We've got a huge population with diverse backgrounds, different cultures, different languages, different ways of doing things. And sometimes it's so easy to walk into a patient's room and make assumptions just the way a parent might look or the way they might handle themselves as to how they might want to be included in the care. So it's always best to ask instead of making assumptions. So one very kind of tangible example, my husband is very much involved in my daughter's care. She's 15, she's been in diapers for 15 years, and it fascinates me sometimes where when he's staying in the hospital with her, when we take turns, it just automatically assumed that he won't do any of the care responsibilities when he's very much willing and involved. But when I come in the picture, it's almost role reversal. Well, they just expect me to be completely involved. So we get a chuckle out of it sometimes, and thankfully that's a more positive situation. So we're going to go through the 4 principles. The first one starting with respect and dignity. So here's a scenario, and I'm going to ask you a couple questions. So I will require a couple of you to come off mic. So for this first scenario, there's just been a shift changeover, and just put yourself in or just whether you put yourself in the nurse's shoes or this is someone that you're following that is a mentor of yours. So this nurse has had a full patient load and anticipates a very busy day on the unit. She or he proceeds to check on first patient. They go into the room and immediately check the IV placement, IV status, and the other equipment that's hooked up to the patient. All is fine, and the nurse leaves the room. So this is where I require some dialogue. So how could this particular interaction affect the relationship with the patient and or family? What are some of the things that come to your mind?
So what I notice is that it's just very unpersonable. Like they don't talk or acknowledge the patient at all. It just kind of seems like they're there to get their job done and then leave, which can affect strongly the relationship.
Yeah, absolutely. Does anyone have anything else to add?
I think one of the important things when we're working with children, like being a mom, I know it takes a little bit more work to have a child trust you. So you have to take that extra time to have those conversations and let them know why you're doing things and what it means. And it's not a robotic thing. Like you have to focus on that therapeutic relationship and maintain that throughout the process of nursing, right? So at initiation of the relationship and at the end of the day, saying goodbye and letting them know like when you'll see them next or anything like that to maintain that relationship.
Perfect. Yeah, thank you very much for that set of comments. So based on what was just shared, what would be an alternate way of checking the IV? Like create a different scenario, a more positive one for me. Is anyone willing to do that?
I think like at the very minimum, like I feel like the nurse could acknowledge that she's having a busy day and that she'll be back to like get to know the patient more, just to let them know that that's not her regular routine and that she does genuinely care about the patient and their experience.
Yeah, absolutely. Does anyone have anything else to add?
Maybe like she can go into the room, introduce herself, and then say like, can you tell me your name? And while she's checking the wristband, she can also check the IV and like check the IV lines and stuff like that.
Definitely. Yeah. So to strengthen, again, all those safety checks. And it's also an opportunity, even though the nurse might, like this might be the first thing that she needs to attend to, and then she'll come back and do any follow-up. It's probably important to understand if there's anything immediate that needs to be actioned, if family member, mom or dad or grandparent, notice something as part of, again, that whole safety process, just to connect, whether it's communicating directly with the patient and or family member, just depending on the age and capacity of the patient. So absolutely, good job on that stuff. Okay. All right, so this is just like literally a new addition to my slide deck that I just wanted to share with you. So recently, our Child and Youth Advisory Committee met, and they were tasked to come up with some stories that reflect some of these principles, because it is Patient and Family Centered Care Week right now that we're celebrating in Alberta Health Services. So I thought some of their stories were very touching and appropriate to illustrate some of these principles. So for this, this particular youth, so this is her story. When I was 3 years old, I was diagnosed with a rare condition. My mother noticed that something was clearly wrong, so she sought out help. She searched and searched for the right doctor who would be able to diagnose what was wrong with her daughter. After many doctors turning her away, she finally found a doctor who would listen to her and had figured out what was wrong with her child. I have now seen this doctor for the past 14 years, and during my healthcare journey, I've been respected, encouraged to participate in my health, and have collaborated with my healthcare team. This is a great reminder for me. When we moved to Calgary 8 years ago, we had to take our daughter to emerge because she was having some seizure activity, and it was just so empowering when I explained to the nurse, the first nurse that saw us, like, I don't know what's wrong, this is new, and she was just so validating to say, you know what, if you say this is not her normal, I believe you. And there's years prior to that going to another emergency department, another city, where you just felt that you were just kind of adding to the day's work and just inconveniencing the staff. But the way that the nurse was able to acknowledge and validate the concerns that I had was so empowering and respectful. So the second story for this section, Grace's story. I've often experienced the feeling of powerless or being left out when it comes to being the sibling of someone with medical issues. Being around my brother all the time, I often felt that I could help, but was not given the opportunity. When my brother's doctor finally asked me my opinion, I was able to give insight that helped. It was so rewarding. Simply being acknowledged as an important part of a patient's support system is very impactful. So unfortunately with COVID, siblings are not exactly allowed on the unit, but prior to COVID, and hopefully at some point, sorry, I'm not even pressing anything, siblings will be allowed in the room, whether it's on the inpatient side or ambulatory side, and whether you're a nurse or a physician or any role that you're going to be playing, it's really empowering to include everyone in the family as part of the care team, and even just acknowledging them that they're in the room is something as simple as that. All right, so here are just some summary ways to practice respect and dignity. I can't remember who said it. Chloe, was it yourself who talked about introducing yourself when you go into a unit's room? If it was someone else, my apologies. But nod is such an important tool within any healthcare environment. So it's not only just about introducing yourself and explaining your role, so distinguishing yourself from a physician or an allied health professional, but what are you doing in that particular interaction? Are you there to just check to make sure that everything's okay, or you're just checking in with the patient and family whether they need something? If it's giving medication, we're really encouraging families to play a role again on that safety team to know, well, what medication are you giving and what's the dose? Especially when there's a lot of changes, use families as part of your safety team. Making your patients and families feel welcome and at ease. It's funny. I don't care if someone just refers to me as Riley's mom. Sorry.
Please return to the unit.
But some of my peers, they don't want to be called as their child's mom. They want to be called by their name. So it's recognizing that we're all different, and there is a whiteboard in the rooms at ACH and a lot of hospitals around the city as well. So if you're not sure, just ask. what's your name? What would you like me to call you? It's okay if you're the fourth nurse that is on shift. If the information's not there for you, try to just get the confidence and ask. Nobody's going to fault you for that. Treat your patients as people first. I've learned so much from the various nurses that have come into our life. My daughter's nonverbal. We don't know how much she understands. And for those nurses who have just taken that approach that I'm going to assume that she knows everything. So I'm going to explain what I'm doing, why I'm touching her, what is going to happen next. Those are some really valuable lessons that I've carried home with me. Acknowledging, responding, and validating fears. We don't expect you to be social workers or our best friend or counselor, but as you can appreciate, there are some crazy things that families can experience when they're in the hospital, and it's okay to acknowledge that, yeah, I understand you've had a rough day, or last night did not go well. And sometimes just that little validation goes a long way, and it contributes to building that relationship. And there's also just, these are just little things, and there's lots more, but knocking in and asking permission before coming into the room. And it's just remembering that even though a hospital, a patient room is technically not the patient's room, but just who knows whether they're being changed or they're changing, whether just or the parents changing, because once you see some of the rooms, you'll understand that it's challenging. So just knocking and just saying, I'm Juliana. I'm coming in and just checking the dressing. Lastly, on this list, make apparent that appropriate hand hygiene standards have been followed. And it's so funny. This slide obviously was created before COVID, and it's something that we've actually struggled with. Some families who have immune compromised children, they're on this. They're always looking, okay, did someone come in and wash their hands, and or use the hand sanitizer, and despite the best of intentions, some people forget. And but now, of course, we're in a completely different world, and this is done constantly. So any questions about practicing respect and dignity? If you've encountered a particular scenario that you've struggled with, or anything that you want me to elaborate on?
Juliana, could you
Yes.
speak a little bit to culture in relation to respect and dignity? Or do you feel that?
Sure.
Yeah.
Yes. Sometimes it's more obvious when someone has different cultural values and beliefs, and sometimes it's not. So if regardless of how long a patient might be on a unit, and ideally, if you are the first nurse, you're capturing this information and you're putting it in the file, so the next nurse, the next team that's taken over doesn't have to repeat this, and you go in more educated and looking like, oh yeah, we've done successful kind of communication handovers. But if you're that first nurse, or the information's not in the patient's chart, it could be as simple as saying, do you have any cultural beliefs or shoot, the words are escaping me right now. Do you have any cultural influences that you'd love to share with me? It could be as simple as that. Especially if you see some signs, some symbols. And we do have a spiritual advisor, and we have a chapel, and you don't have to be like formally religious to draw on any of these services. And if you're not comfortable with asking specifically, can you share more about your culture with me? You could just ask, well, can you tell me more about what's important to you and your family? Or what should I need to know in order to help you out today? It could be as basic as that. Tammy, based on your experience, do you find that there's some better verbiage that you have found to be helpful?
No, I like all of your suggestions. I think that we do work with a very multicultural community, and a lot of times different cultures and ethnicities parent differently as well. There's lots of things rooted in their, their culture that influence things. So I think that's just something. I see that as just being aware of that and being knowledgeable about that, acknowledging that is sort of fits in that respect and dignity piece.
Yeah, and you can even phrase it, I was just thinking, because you don't want to appear that you've singled someone out because maybe they're dressed obviously different than maybe other people. You could even say, you know what, I ask this of all of my patients and families. Do you have any religious or cultural beliefs or that you would like to share with me to help me in caring for your child and your family? So you can make it broad that way.
Mm-hmm. Good suggestion.
Information sharing. All right, so another scenario. You have a 5-year-old child with a neurodevelopmental disorder who's not gaining weight on an oral diet and has been seen in the emergency department a handful of times for dehydration issues. The child is an obvious candidate for a G-tube, but the family is so resistant to the idea of getting one. So given this scenario, who could you recommend and or refer them to speak to? So there's some options on your screen. Anyone want to come off mic and brave an answer?
I think it's E, just because it depends on the situation and how they react. Like if they feel like they're not really comfortable, like let's say if it's an immigrant, I feel like it would be really helpful if they get like a peer support volunteer instead, specifically somebody who speaks their language to kind of make them more comfortable. If you see that there's more like conflict in the family, maybe like a social worker would be more appropriate. I don't know what really the right answer is.
Well, the two answers you've said definitely are on the list that, yeah. Does anyone else have a different answer?
No, I think I also agree with that because there's not really more context to the situation, and I feel like we would need to gain a further understanding as to why they don't want the child to get a G-tube, because that's ultimately gonna change who we would refer them to.
Absolutely, and I certainly did not provide much context. Technically, once you learn more about what their concerns are, any of these could be included. Just think of them as part of your toolkit. And depending on what information you obtain from the family, you can reach out to any one of these. So we do have a peer support program here at ACH that nurses can refer to. Sometimes nurses will refer to the social worker who will then refer to us. Depending on the situation, ethics might be the appropriate person. I've got a personal friend who was in a very contentious divorce situation, and her child needed a G-tube, like hadn't gained weight for 4 years, and she was about 15 as well, and they just got one. It didn't go to ethics, but it could have. And ethics is not just for families. Like families can access them themselves, they can be referred. But if you're struggling too with a medical decision, or maybe no decision is made when you think there should be one, you also can reach out to ethics. The point of this scenario is just to understand that in most organizations, these services should exist, and then it's just understanding, well, when should they be pursued? And sometimes you try one and it may or may not work, and you might need to pull on another one. So it's really important to know when you're in a care setting, to know what options exist, what exists in that tool set that you can draw on as needed. Okay, so next scenario. So it's questionable whether the parents of a patient speak English proficiently, enough to make informed treatment decisions for their child. What should you do? And here is a whole list of scenarios. I'll let you read them, and then if someone can come off mic and give me what you think the answer might be.
I think that the risk that we would be running by using the teenage child who speaks English proficiently for the parents, the risk that you'd be running is it's still emotional because that's a sibling. So as much as I'd want to say B, and like obviously you want to communicate the best you can't, that's not making sure that they're making informed decisions. So I might say D and E only, just to make sure that they're getting that information.
Thanks, Kendra. Does anyone have any other answers?
I would also say D&E. I actually had a situation like this during my second clinical, and my primary had been using the daughter to communicate, and it was just, you could tell like the daughter was kind of stressed about always having to be reached and like being like responsible for doing all that translation. And then also, like Kendra said, having that relationship and like being tied is also really heavy because they're trying to process it at the same time they're delivering that information. And then that way, if you're the one either connecting to phone support or the VRI, then it's like you have that therapeutic trusting relationship with that person because it's between the two of you. And you're kind of almost like empowering yourself and the relationship between you and that patient, kind of a thing. And so I would also do D&E.
Yeah, you guys are correct. You'd be surprised though how often you might see the other options being used. You might even, it's funny how when somebody can't understand us, we often speak louder, thinking that if we're louder, that will help with the translation. No, of course that doesn't work. And unfortunately, there's lots of situations where we rely on another sibling. Like I've heard tons of stories. It could be an 8-year-old, and that's like, as you guys said, a huge responsibility for that child, let alone know whether they've actually did an appropriate translation for their parents, especially when there's a big decision. Of course, I mean, I can almost guarantee you, I shouldn't guarantee you, but on really big decisions, I hope that none of our healthcare providers would ever rely on that. But sometimes it's the smaller decisions that we think, oh, it's okay. It's okay if I just ask that 8-year-old or other teenager. And with a staff member too, we've done that before, and there's a story from a few years ago. It was in an adult emergency department where the staff always volunteered to help families who come in who speak this particular dialect, an Indian dialect, and she was so happy that she could help these families. And then when AHS said, all right, we've got to certify any staff who wants to act as a medical translator. And so when she went through her certification process, they found out that she only had a grade 1 level in that language. So you can just imagine what might have been lost in translation. Yeah, true story. So we've got lots of more robust processes in place now. And the really cool thing at ACH is these video remote interpreters. It's an iPad on wheels, and people can actually see someone. And it's empowering. It doesn't take much time. And I think that's the biggest thing is a lot of people think, oh, I don't have time. But if other problems or implications arise, then you've just actually created more work. So wherever you are, find out. Don't let anyone dissuade you to leveraging the language line or a video remote interpreter if it exists. Okay, so here's another story. Yeah, absolutely.
So how would you deal with a situation where you as probably as a nurse walking into a room and having a conversation with a family, and then someone takes up the role as the interpreter. Say you're speaking to the patient, and then a family member is in the room interpreting. So do you just so how do you handle that situation?
So would it be another staff member acting as an interpreter?
No, a family member.
Oh, okay. If the family member is not a parent or guardian, I would simply say, you know what, we have access, just because I want to make sure that the information I relay to you is accurate and complete. I think it's in everyone's best interest that we take advantage of the interpreter services that we have, and then proceed. I know some on the ambulatory side, when it's known that a family is not proficient with English, they will actually book either the VRI machine. If it's warranted that someone comes on site again pre-COVID, then they'll actually book someone to come. So they try to screen as much as possible in advance. But if it happens in the moment, then it's better to pause, even if it means rescheduling the appointment depending on what's being discussed. Does that help?
Yeah, it does. Thank you.
Okay. I know it's not easy, and I know it's so easy just to potentially continue, but if there are safety consequences, it's much better to pause and come up with a new plan. All right, information sharing. So this is a story by Jordan. Immediately after receiving my diagnosis, I felt overwhelmed by the information that has been shared with me. I felt scared to go home, not fully understanding what I should expect. One nurse recognized that my family and I felt overwhelmed. She took the time to explain the information in a way that was easy to comprehend. She allowed me to ask questions and gain a better understanding. With the help of the nurse, my family and I better understood my diagnosis. We were able to go home feeling more comfortable knowing what we should expect. So I just find these words to be so powerful, and it doesn't take much time. Even going into a patient's room and just asking them if there are any issues or if there's anything that you can do, and just taking that extra little bit, could be as little as a minute. And in this case, don't know what the diagnosis, and that's weird, there's a ghost, I'm not even touching things. Don't know what the diagnosis is, but so often we hear when someone's given a major diagnosis that the impact on that family is huge. So allowing them to go home and better process the information is invaluable. Okay, so here are some practical strategies. Just moving. So use plain language and limit medical jargon as much as possible. Ask open-ended questions. So especially if you feel that there either might be a language barrier or just even an understanding barrier. Not everyone has gone to school. Like I went to business school. I certainly did not go to any medical related school. And so sometimes I don't know what to ask. We often don't like creating space for just silence for people to process things. And I'm always gently reminded by a colleague, she's like, I need time to process. So don't expect me to respond right away, whereas I'm a fast processor. And so that's always been a good reminder for me. Always speak facing towards the patient and family. And I know it's more complicated with us wearing masks. Some people will actually have a picture on their ID tag that they're showing more prominently just to help create that more intimate connection. Practice active listening, explain, explain, explain. Often when there's been rounds in my daughter's room, there are times where the nurse will be present, and once everyone leaves, I'll ask the nurse, what did they say? What did they mean by this? So you're often our translators, or you're peeling me off the ceiling based on what was said or wasn't said, and you can help create the go forward plan. and use multiple methods of communication. My husband and I have different learning styles. I can retain a lot during verbal conversations, but my husband, he needs things written down so he can further process them. So sometimes it's even being asking the family, how would you like me to best communicate this information? We can have a conversation. I can write down some points. I can leave you with some points or a brochure. So it's okay to ask. One surgeon, I remember to this day, my daughter's G-tube came through her stomach and she needed surgery, and the surgeon on some cloth, she wrote out, because that was the only thing available, it was the sheet. She wrote out exactly what she was going to do for both my husband and I to understand and fix it. We often have the habit here at the hospital just to give a brochure. Parents don't read brochures. I mean, they're good to have as a backup, but if you're going to give a brochure, point out like a really important message or what they need to take away from. Or if you've just had a really heavy conversation, there's been a lot, like of course you ideally don't want to overwhelm a family member or a patient. And sometimes you don't know until you get started. But when you see kind of that frozen look, or they're just not taking it in, you can say, okay, I've given you a lot of information. Can you just share with me what you're taking from it, just to make sure that we're on the same page? Or what do you take away as the next step from here? Throwing it back to the family, and then you can clarify or start over if you need to, or start at a different place. Any questions about information sharing? Okay. Participation. So we've got another scenario. We've got an 8-month-old patient. The diagnosis is not relevant. It's 11 a.m. and mom still has not risen from the parent bed all morning and has not participated in any morning routine care for the child. There is nothing in the chart to give you any information from the previous shift. And I actually got this scenario from an MRU student many years ago as a result of their experience on an inpatient unit here. So I've used it ever since. It's a great one. So what factors might be present to explain mom's behavior? What do you think's going on, or what could be going on? Anyone?
Just the ever-changing environment. Like patients and families always get overstimulated with everything going on, and then the fact that we're switching nurses every 8 hours. Like, yes, that seems like a long time for us, but for families, it's like so fast, and it's like nothing ever stays constant, and it's confusing. And then it's like, okay, when do I actually rest? Because everything is changing, and I have to pay attention to everything going on.
Yeah, that's one great scenario that could be happening. Does anyone have any other thoughts about the mom situation?
Just depending, again, like the diagnosis is not relevant, but maybe the mom feels like a bit helpless and doesn't know how to handle her child's illness, or maybe it's a very new thing and she feels just kind of like if she can't help in this way, then kind of she might feel like, what am I good for? So maybe she's just discouraged in that sense.
Yeah, absolutely. Great point. Anyone else?
I think kind of just adding on to that as well, as parents may start to feel like maybe it is the nurse's job to do it as well, to get up and do the care, and they just get used to that process because maybe some nurses will do it for them and maybe others won't. So it might be confusing for them. They also could just be super duper tired as well. So
Yep, excellent point. So what do you think if you were the nurse, not during your practicum, but if you were a nurse and you learned about this for the first time, that the mom has not moved in the entire kind of shift up to 11, what would you do, or what could you do?
You might want to wake her up, make sure she's okay.
Yeah.
You can wake her up with some tea or coffee or something, and then just talk to her about what's going on with her baby, and then maybe that can lead into what's going on with her.
Yeah, absolutely. Yeah, so there's so many things that could be going. Oops, sorry. The mom might have, like, it might have been a horrible night, and ideally that would be charted in. The mom could just not be handling the diagnosis in a good way. She could be severely depressed or not sure her role. Maybe we don't know how long, and I didn't know how long in this scenario the mom and babe were in the hospital. Maybe they just came from ER. Maybe there was never a conversation to understand, well, what role the mom could play. So the biggest thing is, don't make assumptions, regardless of how long the mom or babe have been present. Like one of my daughter's inpatient stays, we were here 6 days. We were on a unit that had 3 shifts, so 6 times 3 is 24, and we had 18 unique nurses. So there's a lot of turnover, a lot of opportunities for communication gaps, and almost every single nurse, they're like, okay, you've got to unfortunately repeat to me, well, what's your daughter's baseline? Because the information wasn't being passed over, and that's fine. I understand the system. It's frustrating, but for this particular situation, I had asked the practicum student, well, what happened? And she goes, I have no idea. Nobody talked to the mom. And that's unfortunate, because if the mom needs help, we can get her help. Whether it's talking to a social worker, whether it's getting some other answers, or just maybe that's her preferred time to sleep. Maybe even though the child slept all night, she didn't sleep because of whatever else is going on in her mind. So the biggest message is, don't assume. Have a conversation with her. Make sure she's okay. Talk to her about how she'd like the rest of the day to unfold. Maybe she didn't know that she can change the child's diaper. Maybe she doesn't want to because she's been doing it and just tired. Like for me, with a child who's been in diapers for 15 years, sometimes it's just wonderful when a nurse says, you know what, for the next one, I've got it. But that might look different from shift to shift and why and what's going on. So good. Thanks for all that commentary. So this is the last kayak story. So this individual found 2 pictures. So this young girl here has her eyes covered, and then another one that looks pretty content. And this is her story. So when I was in the hospital a week before COVID, I was really struggling with my medication not working, and no one was there to support me. No one was there to help me. When I advocated for myself and participated in my care, I was able to get on the right medication and began to feel better. I had to make sure that I got the right medication by telling the nurses that the medication I was on wasn't helping and I needed a stronger dose or a different form of medication. Before I was able to participate in my care, I was feeling down and defeated, like the first photo. I'm so sorry. And when I was able to get the right care for myself, I felt much better and relieved that finally something positive was happening, like the second photo. So I love this story because this is obviously a teenager who has the ability to participate in her care. And for whatever reason, she wasn't feeling heard for a while. And it was probably just one nurse that made a huge difference in having that conversation with her and truly listening to her in a way that was able to make a difference. So other ways you can practice participation, just think about you're providing care with patients and families instead of doing to or for them. I know as practicum students, you need experience administering medication through the G-tube or helping with other elements, and just always recognizing that there are patients with feelings and identity, and it's including them as much as possible, and you're working with them as opposed to just kind of completing a transaction or checking off a box on your practicum experience checklist. I touched on this before, asking patients and families how they want to be involved in the patient's care, and recognizing that again, if you're on a particular unit and working with maybe the same family over a couple of shifts, it might look different shift to shift depending on what's going on. So don't hesitate to whether it's renegotiate or open that conversation saying, oh, for the rest of my next shift, would you like me to give your child their medications, or is that something you would like to do? Or the next diaper change, or other things like that. And wherever possible for patients, if they've got the ability to actually participate in their care, whether it's by choosing what arm a needle goes into, or if blood has to be drawn, what arm, if there is a choice that can, include them. And acting upon your patient's family's questions and concerns, I think that would be a pet peeve of all of us. If somebody said that they were going to go do something or follow up on something and then never got back to you, and it's okay to say, I'm not sure when I will get back to you, but I will before the end of my shift, or keep it open and honest. And if you're not sure, especially when you're learning, it's okay. You could say, you know what, I don't know the answer, but I will do my best. And if I can't get it for you, my whoever's tagged to you as the nurse, or you'll pass the information along. Don't make promises or commitments you can't keep. And if you said you were going to do something and you realize afterwards you can't, then go back to that patient and family and just say, you know what, I thought I was able to get this information for you, but I can't, and here's the reason, but here's what I'm going to do about it. Oh, sorry. Trying to negotiate this whole new world. So practice, teach back. That's so important, especially helping families get to the discharge date. So depending on why they're here, it might be a dressing change, it might be they've just got a new G-tube, or some other element. Make sure that you're not doing all the work. If they need to have those skills at home, figure out a way that they can learn those skills over time or on the shift. And if they're resisting, then you've got to figure out, well, how do I solve this problem? Because if they go home without these skills and something happens, they're going to land back and emerge, and certainly they do not want to come back as an inpatient. So teach back is a great strategy. And I find too, and again, a lot of nurses and nursing students have taught me a lot in kind of customer service as well, like thanking patients for allowing you to be part of their care, especially when you're a student. I mean, you get exposed, it's so intimate, it's so, like, you see parents and patients kind of are the worst in so many ways. So just to acknowledge that you've been able to participate in their care experience, it helps again with that relationship. And then it helps the next student as well, because you guys are learning and might take longer than what would it normally take for a particular transaction or procedure. So just creating that little bit of faith. So I knew in advance that I wouldn't have time, and we're just at 12:30. My apologies. We're almost done. You will have the slides. I would really, really highly recommend that you go to this YouTube site and like the Talk With Me campaign that's being produced by Sick Kids. They have done a really lovely job of answering the question of what patients appreciate. So it's a worthwhile 6 minutes of your time. Briefly, what do parents appreciate? So we've pulled a lot of frequent flyers in the hospital, and these apply to anyone who needs to be here. Demonstrating nod, sharing plans and expectations for the day or the week, depending on the situation, consistency of information from shift to shift, treating the patient as a person and not their diagnosis. So my child is a 15-year-old child who just still happens to love Winnie the Pooh, versus a child who has Rett syndrome and some other crazy stuff that's happening. Coordinating care. So if you have to do an IV check and other things, bundle it up if possible, as opposed to having to come back every hour on the hour. It just helps with a better experience for everyone. And then also recognizing the family expertise. Some families don't realize they have any strengths to bring to the table, especially if their child has never been in the hospital and there's something new and new happening. So it's just helping them figure out what role they can play. Maybe there's a family member that has the greatest sense of humor and helps distract the child from a horrible procedure. It could be as simple as that. Tammy, do I have 2 more minutes, or do we have to cut it off? Which is fine if we do. We're good? Okay. Okay. So the fourth and final principle is collaboration. So there's no question collaboration happens at the bedside. But when we look at these 4 definitions, at least in our world, we refer to collaboration that happens actually beyond the bedside to the boardroom and in between. So here at not only just Alberta Children's Hospital, but at Alberta Health Services, we are committed to including the patient and family voice. And we refer to that as kind of patient and family engagement. So we have included them over the years in a variety of different ways, from helping to design new policies and procedures to being direct participants in quality improvement projects, etc. So AHS is committed. So just depending on how your career evolves, whether you end up in a leadership or management position, know that it's so integral to talk to the consumer, talk to the patient family, and understand what their perspective of a particular service or experience, and use that input and feedback, because it always builds a better solution. So it's no different than if a hospital is going to be making some fundamental changes that affect nurses, but there's no nurse at that kind of project table, you would want some representation, and it's no different with patients and families. So we're doing some really cool things through our engagement program. And then this is just a final reminder of just some key points. Get to know the patient and their family. It not only makes for a more enriching kind of relationship experience, but you will find out what truly matters to them, and it helps you focus their care. Identify strengths, talked about that. Providing choice, again, it could be as simple as, hey, we need to draw blood today. Is it going to be your left arm or right arm if possible? Something as simple as that really makes a difference in a child who's got the capacity to play a role. Providing emotional and other support. So again, figure out what can be in that toolbox besides yourself. What other services that can you refer a family to if you know that they're struggling, either with a decision or with an experience, or they need more information and you can't provide it? Just whatever practicum or future work experience. Every organization might have different things in that toolbox, so just think what goes in. Assisting patients and families to be empowered. Again, the best care experience from a treatment, from just an overall experience, is when you include patients and families. And then lastly, maintaining a reflective practice. This is something that every profession should embrace. It's something as part of, like, even this presentation, there are things afterwards that I'm going to be like, okay, what went right? What do I need to make sure it doesn't happen again if I can avoid it? So when you go into an interaction with a patient, not only kind of reflect on, how could I have done that different? But when you've had actually a really positive experience, reflect on those experiences too, to say, what made that so nice or so good or so productive? And maybe you can borrow some of those things for that next interaction, or the interaction that matches what you just experienced. So we're kind of at the end. If anyone has any questions, I would be more than happy to do my best to answer them. Is anyone concerned about a particular scenario that they, or dealt with like a challenging scenario in a past practicum placement?
Juliana, I wanted to ask you, with your experience having a daughter with a disability, if there's any advice you would give to us collaborating with families with children with disability.
Oh, I think I would need another hour for that one. Yeah, and I do have a complex child, and everyone works in silos. But I think the biggest thing is validating that for me, that I am in a tough situation, that it's not easy, and unfortunately you're not able to solve the $1 million question of how to take care properly of a complex child. But it's defining the scope. So what's within your scope of practice? What can you influence and inform? And it's okay to set boundaries around that, but acknowledge that you recognize that there's a lot more going on and you wish that you could influence these other areas. But you've got the ability to make a difference in this particular scope. So just, I guess, acknowledging that scope, and also recognizing the bigger picture, that it's not, there's a lot more going on. And often it is with a lot of people, and it might not always seem that on the surface. Yeah, good question, Kendra.
Thank you so much.
No problem. Anyone else that has a thought or question? Okay, well, if you think of something, feel free to send it to Tammy, and she can send it to me, and I'll do my best to provide an answer. I guess aside from that, I really appreciate being included in your MRU curriculum, and I wish all of you the best in your next practicum in these crazy times. And speaking on behalf of other families, we're just really grateful that you've entered this exciting career, because you can and do make a big difference in our lives. So thank you.
All right, I wanted to say thank you to Juliana as well. There's nothing like having someone who wears multiple hats, right? As a parent of a child, you know, being a parent, and then also having that educational and side of it as well. So you've lived sort of both camps, and so I really appreciated the scenarios, because I think it just brings